Hello, everyone. I am Sally Davies, and it's my pleasure to host today's brochure meetup about rare diseases. Just some very quick housekeeping notes before we get going. The meetup is going to last approximately an hour. We might run a little bit over. In the first half hour, we're going to hear presentations from our panelists who will introduce themselves to you in a moment. And then in the last half hour, we'll open up the floor for discussion. So please do feel free to drop questions in the chat. We'll pick them up in the Q&A if possible, and also if they come up organically in the discussion. So to turn to the subject of today's webinar, rare diseases represent something of a paradox. While each individual rare disease might affect only a handful of people per thousand, together these 10,000 or so conditions profoundly affect the lives of hundreds of millions of people globally. Such statistics present challenges that go to the heart of how we organise society and distribute resources. Healthcare systems are wrestling with newborn screening programs that can detect diseases but can't necessarily treat them. Researchers are developing breakthrough gene therapies while knowing that pricing decisions made in remote boardrooms will determine who gets access. So what does health equity mean in a world in which a child's survival might depend on their parents' ability to go viral and crowdfund? How do we balance the needs of the few against the needs of the many, and who decides what a human life is worth? In these and many other ways, the rare disease landscape reveals both the extraordinary promise of modern medicine and its profound limitations. So today's webinar brings together 4 leading researchers who approach these questions from complementary perspectives across economics, policy, anthropology, and ethics. I'll now ask each of them to introduce themselves before they provide a short presentation on their work. I'm just going to go in the order I can see you on the screen. So Malgorzata, I'll start with you.
Hello, everyone. It's really nice to be here. And thank you, Sally, for this great presentation of the topic and introduction to the topic. I am Malgorzata Rajtar, and I'm an anthropologist and sociologist. I'm based at the Polish Academy of Sciences, the Institute of Philosophy and Sociology. I also had the Rare Disease Social Science Research Center, one of very few in Europe social science centers that focus really on rare diseases. So yeah, that's me.
Thank you so much. Khadidja.
Hi everyone, my name is Khadidja Abdallah. Thank you so much for inviting me to this webinar. I'm looking forward to the conversation. So I have a background in biomedical sciences from the University KU Leuven in Belgium. And I did a PhD on budget impact and payment approaches for orphan drugs, which is about 2 years ago now that I finished. And yeah, I'm looking forward to this conversation, maybe a bit about my role now. I'm a health economics and outcomes research and real-world evidence manager at Bayer. Thank you.
Thank you so much. Wim.
Good afternoon. My name is Wim Pinxten. I'm professor of medical ethics at Hasselt University in Belgium. I did a PhD some time ago on clinical trials in minors, and there I first got in touch with the topic of rare diseases and orphan drugs. And in the aftermath of that, we once organized a symposium at the Brochet Foundation in Geneva, and very happy to continue the discussion today.
Thank you so much. And Eva-Maria.
Hi, everybody. I'm Eva. I'm with the Austrian Academy of Sciences. I'm a medical anthropologist. I worked for quite, well, over a decade now in endemic settings of rare inherited blood disorders, especially thalassemia and sickle cell disease, with questions of health equity in an archipelagal setting. So I was always interested in these center peripheries, namely in the Maldives. And lately I also turned to Austria, where we have also this interlinkage of rare diseases and migration, which I'm going to talk about. And I'm quite happy to be here. Thanks to organizers.
Thank you so much. So I'm now going to invite each of the participants to give a brief presentation, and then we'll unpack them in Q&A. So Malgorzata, I'm going to start by inviting you.
Thank you. Let me open my screen. Okay. Can you see it? Yeah, perfect. So hello again, and we can skip this part. I will be focusing on the Polish case and maybe a few words of introduction. Sorry, I need to start again. This. Okay, so just a few words to maybe add some information on rare diseases. As you may know, rare disease, there is no universal definition of a rare disease, and in the European Union, and this is also a definition that Poland has accepted, disease is considered rare if it affects less than 5 in 10,000 people, and about the estimated number of people with rare diseases in Poland, in Europe is 30 million, and in Poland about 3 million. And what is important, and Sally, you already mentioned this, is this heterogeneity and variability of rare diseases. So, and also something that we can pick on in the Q&A session, it's the vulnerable situation of people with rare diseases. And this is how the key EU documents characterize these conditions as life-threatening, chronically debilitating, and characterized by low prevalence. But social science perspective and literature also emphasizes that the definition of rare diseases is an inherently political definition, and it's something that's worth remembering. When it comes to Poland, Poland was one of the last countries in the EU to adopt the Polish plan for rare diseases. We did it only in 2021. It was a short-lived experience, and now we are in the implementation phase. That the plan focuses primarily on expert centers, registers, diagnostics, and patient passports and cards, and I'm happy to talk about it later also in Q&A session. And it has been generally criticized for its biomedical focus, which was partially because just the Ministry of Health has worked on the plan, and it was kind of impossible to get involved the Ministry of Education and Ministry of Social Affairs to help in preparation of the plan. The Polish Ministry of Health has recognized rare diseases and made them as one of the governmental health priorities in 2021. This does not, as I will say later, quite translate into the practice. And what is important is the fact that in Poland, 30 rare diseases are included in newborn screening, and it's one of the largest numbers in Europe, right after Italy. And there is a push to even expand this number, and that's also an important thing. Just a few words. I have been working in the field of rare diseases, doing anthropological research since 2016, with the main focus on metabolic diseases and comparative studies for a long time between Poland, Finland, and also in one project we had Sweden. And recently I started also working in collaboration with Eva on transition in rare diseases, because about 70% of rare genetic diseases are or affect children. But we have now a growing generation of children and young adults who turn into adults. And this transition phase, transition from pediatric care to adult care, has become a very important topic that also is wrought with challenges, ethical challenges regarding autonomy, relationality, and other things. So inherited metabolic disease, maybe I can skip this part just to speed up what I wanted to mention here is a recent survey conducted by the National Forum for Rare Disease Therapy, or FAN. It's a Polish umbrella organization that's part of the EuroDis, a European umbrella organization that conducts regular yearly surveys among patient organizations in Poland. And a few things are worth emphasizing is that 72% of organizations in Poland emphasize that that the rare disease plan has not really improved the situation of people with rare diseases, that the needs of people with rare diseases aren't really treated as a priority, despite the official discourse and healthcare policy documents. And also, the 91% of patient organizations indicated that there has to be changes in social care for people with rare diseases. And this is the part where basically anthropology also, with its focus on context and people-centeredness, but also critical approach comes in, where we look at the living situation of people with rare diseases and their caregivers, and also how the health policies, like the, let's say, patient passport and patient card, may translate and may affect people in practice. And that's something that I'm also happy to talk about. And then there's, of course, the access to medication and reimbursement that are of a huge concern and are still an unaddressed need in Poland. And just to sum up, I'm really happy, just a few publications, not all of them, but I'm really happy to talk more about both health passports, vulnerability, but also on data and stigmatization practices that, let's say, newborn screening and other policies may introduce. So thank you so much.
Thank you so much, Malgorzata. Lots to come back to there. And I'm sure that some of the other panelists will pick up on some of those themes in their presentations. I will now invite Wim to give his presentation on
try to share my slides. Does that work?
Yeah.
Okay. So if we look into the ethical issues related to orphan drugs, there are, of course, very many. And I'll just try to take an easy start in a world where public healthcare financing is under pressure constantly, not only because of the high prices of new drugs, but also silvering society, demographic changes, and very different factors. We need to spend money wisely, of course. And if we try to consider the rational allocation of limited resources in a big domain like public health care, it's often many billions we spend. There are criteria we can agree upon that are important in deciding whether or not a treatment might be a good candidate for reimbursement. First one is, and it's a concept also used frequently in the domain of rare disease and orphan drugs, is there an unmet medical need? Are there already treatments available? Do we need something new? What kind of progress can we make for patients? Obviously, a reasonable and important criterion. Other concerns can be, does a treatment work? And then we want to know, how well does it work? And how well do we know this? What kind of change can we expect? And do we have real proof? In rare diseases, orphan drugs, this is sometimes a bit more difficult than in other domains due to the small patient populations, smaller clinical trials, and so on. So there might be some more discussions. Is the price reasonable? Prices are sometimes subjective, and we'll discuss later on the ethics of price setting. But the reasonability depends on many factors. And the last question can be, can we afford it? But if we consider a list like these, and you could add or delete criteria, of course, what should be something we notice is that there's not on the list that it matters how many people have a certain condition. Whether your disease is rare or not, in fact, doesn't make any difference on your medical need, on what can be done about it. And the same is, in fact, the case about the price of the treatment. Maybe it's unaffordable, but price and rarity shouldn't be criteria as such, whether or not a treatment can be open for reimbursement. And if we look at reasonable expenses, we like to make rational decisions maybe and expect that we are good at doing that, but we often make exceptions. And especially when it comes, for example, to children in a direct life-threatening conditions, exceptions are being made. And I'll just give an example for a completely other domain. This is Julen. Julen was a toddler who fell into a borehole for a water well in Spain in 2019. And once something like this happens, he was still alive, 70 meters underground. No efforts or costs are being saved to try to save him. And you can say, yes, but this is really rare. It's a bit the same for rare diseases. It won't happen twice. Well, in 22, there was a similar case in Morocco with Rayan, also fell in a well. And we try to do, even with little outlook on a happy ending, whatever is possible to save people, and especially children, in a very big need. So a lot of efforts were being made. And this is something you can do in exceptional situations. But of course, in policy work, you need different frameworks to decide. And one of the things that will come up, I'm jumping from the one part to the other, but we don't have much time for the talks here, is the issue what would constitute a fair price? Because we see pricing that run up to millions of euros for the treatment of an individual patient. And one could ask, well, what's determining the price and when is a price fair? And you could just consider a number of potential systems to determine price. And one would be, we have the production cost and reasonable profit. This is a bit beyond discussion that people who enter the market are allowed to make some profit, and they start from their costs and they add 20–30% or whatever needed to be profitable, to be entrepreneurial, and so on. But the issue is that most often, when we look at the high prices of orphan drugs, this is an unlikely calculation method. We take different methods to calculate, and it doesn't work in all domains. For example, when you want to buy a painting of a famous painter, he won't just charge the price of the paint, the canvas, and some working hours. It's a different way of speculating, determining the value. Another way, and that's frequently used in justifying the price of an orphan drug, is a cost saved on other treatments and care, for example, in a time frame of, let's say, 10 years. We might be a bit optimistic that nothing else will enter the market in this time frame, but we could try to calculate how many costs are saved, and that could justify for these very high prices, because alternatively, if you don't treat, costs will run up anyway. And a last way of looking is what clients are willing to pay on a free and anonymous market, and then the market will set it. But most orphan drugs are out of reach for out-of-pocket payment, so you really need government to interfere to make it affordable. And if we look especially on these cost saves on other treatment and care, what is called value-based pricing, it's ethically a bit problematic, because just suppose I would need new glasses, I would go to the optician and he would say, I apply value-based pricing. Let's calculate how much you save with new glasses. You can drive your car, you can read books, you can continue your job. If you don't, you will have excessive costs. So I estimate the price of your new glasses, let's say 400,000 euros. Nobody would be happy with this, but they don't charge me such an amount, and that's because there's competition on the market. And exactly this is sometimes lacking logically on the market of rare diseases and orphan drugs, or orphan drugs for rare diseases is a better explanation, which explains that prices can run up to these very high amounts. And then we can ask, well, is it worth the price and how can we deal with it? And we see that markets can be volatile. If we look at economic value, we can see that, for example, now currently a frequently used system to determine the price of tickets for concerts like Bruce Springsteen is dynamic prices. Ticketmaster, for example, uses it, and then the price is determined depending on the number of people wanting a ticket. So while Bruce Springsteen in the beginning of his career said that $10 was too expensive for a concert because students couldn't afford it, now you can easily find tickets priced 5,000 euros and more, just because of a different pricing system. And then the question is, what is the inherent value of such a thing compared with the economic value? Because on an anonymous market, you won't have nice prices. It's the right of the strongest. You don't have a control on the price. And while things may have an economic value determined by the market, there's also the inherent value, for example, of health or, for example, of art. This is a painting of a doctor, not by coincidence. We're in a medical topic today. It's Dr. Gachet, one of the last the doctors that treated Van Gogh during his lifetime. And it's kind of a miracle that nobody during his lifetime could value Van Gogh. Nobody had seen what a wonderful artist he was. Later on, people did, while during his lifetime, he wasn't able to live from his art. In 1919, this painting was the most expensive painting ever sold on an auction, and it went 171.1 million euros, which was a lot of money back then. Right now, it would be worth already several times this amount, and it was bought by a Japanese paper trader who said, well, when I die, to avoid taxes on the inheritance, I will cremate it together with my body. Because I determine the value because I bought it on the market. This, of course, doesn't always make sense. And we need to find ways to appreciate real and inherent value, sometimes independent from a market. And for health, this is extremely difficult. Government has a very big role to play in this. Belgium just announced a few days ago that they have a new system to provide early access to new drugs, maybe in some cases even before EMA approval, which also will raise some ethical concerns, obviously. But if government doesn't play a role, people will try to find their own access to orphan drugs. As happened in Belgium, we had a very successful case of crowdfunding in which 2.1 million euros were being raised to pay for a Zolgensma treatment for a baby with SMA type 1. It has been documented. I also published the case. It was raised in a very short time, but with a lot of luck and coincidence. And let be what we don't want people to be dependent on when they are in high medical needs. I'm going to finish the story here, but open to questions later on.
Thank you so much, Wim. I'll invite Khadidja now, who will also be looking at pricing for orphan drugs, I believe.
Yes. Is that okay? Okay. So I'll have a talk on a case study that I did during my PhD, and the case study is about evaluating the financial impacts of innovative sickle cell disease treatments in Belgium. Right. Sickle cell disease is a monogenic disorder that is caused by a point mutation in the HBB gene that is responsible for producing hemoglobin. Hemoglobin is a protein that carries oxygen in our red blood cells and across our bodies. But this point mutation causes the red blood cell that is normally round as a form to become sickle-shaped, which then can lead to blockages in the blood vessels, and then inflammation follows, and many, many more complications. Depending on the genotype or the severity of the disease, there's different symptoms that patients can experience, but the most prominent symptom is vaso-occlusive crises, which are basically just very intense pain crises that are very debilitating for patients. And other more extreme symptoms are strokes, acute chest syndromes, and different infections. It has been estimated that the lifetime cost to treat patients with sickle cell disease is around about $2 million US. It is more so present in malaria endemic regions, and child mortality in low-income countries is about 90%. But in high-income countries, 95% of the population reaches adulthood, but they do have a 20-year shorter lifespan. And because it's characterized by a very low quality of life. So is sickle cell disease actually rare? In Europe, it is considered rare. However, if we look at the global picture, there's about 8 million people that live with this disease, more so in malaria endemic regions. In Europe, there's about 52,000 people affected, with most of the patients living in England and France. And Belgium has around 2% of this population, so about 1,000 patients. So because the disease is considered rare in Europe, any drugs that are developed for this specific disease can be labeled or can get an orphan designation, which is a status that is given to drugs that treat less than 1 in 2,000 patients, and also a disease needs to be life-threatening and chronically debilitating. Now, this orphan designation that is given by the European Medicines Agency comes with different incentives, such as market exclusivity, meaning that a company has 10 years of complete ownership of the drug, so no competitors can come onto the market, which then also often leads to very high price tags characterized with orphan drugs. Now, market authorization, or before getting the drug to the patient, it needs to go through this rigorous process, which first starts at market authorization. And in Europe, that's done on a European level. So the European Medicines Agency decides if the drug is safe and efficacious enough to be marketed. But then after that, each individual member state or country in the European Union decides on the value of the drug. So is this drug valuable enough for us as a country to decide to reimburse it and give access to it to our patients? There's different types of analysis that are done, but usually a health technology assessment is conducted. And one of the analyses that I'm going to get into now is budget impact analysis. It's part of this assessment to more specifically decide on affordability of a certain drug. So it kind of looks at a healthcare system. Let's say in this case, it's Belgium, and we look at sickle cell patients specifically. How are they currently treated, and with which drugs are they treated? How many patients are there in Belgium, and how much do these treatments cost currently? So that's the current budget. That's then deciding how much the current budget spends on sickle cell disease. And then what we want to do is, now, if we introduce new therapies that are that want to, let's say, be commercialized in Belgium. So if we now decide to reimburse these drugs, how much of an impact would that have on our current budget that already treats this set of patients? So this is what this analysis does. And then depending on that, it could kind of give an idea of how, if the drugs are affordable. Now, this is just an overview of like the cost, the list prices of the treatments, let's say the cost per year. For example, the current interventions range from 600 euros a year, which is pretty cheap for hydroxyurea, but goes up to about 240,000 for stem cell treatments, which is also just a one-time treatment. But then the new interventions these past years range from about 106,000 for Vexelator for one patient for 1 year. That would be the cost. And then you can see on your right, all the way to the right, Casgevy is the gene therapy. In our analysis at the time when no list price was known, we used 1.4 million. However, it's now, I think, 2.2, valued at $2.2 million. So these are the list prices that I worked with in the analysis. And what did we then see? That if we look at 5 years after introducing these drugs in Belgium, it would have an effect of about 30 million euros on the drug budget. And 85% of this drug budget, this impact was due to the gene therapy. Now, is Belgium capable or to afford these drugs? If we look at the healthcare budget in its all, which is 35.3 billion euros, it looks like obviously we can afford this. But like Wim said before, there are so many other other diseases, and the healthcare budget is limited. So we really need to see where do we spend our money. Because the introduction of these new treatments would have an increase of cost management of sickle cell disease of about 1,500%. And there's different thresholds that different countries use to define if a drug is affordable. In Belgium, there's no specific one, but if we compare it to the one in France, which is a threshold of 30 million, the two drugs, crizanlizumab and voxelotor, would be okay, which very below the threshold. But the gene therapy, which had an impact at 37 million, would be very much above the threshold. So the budget impact is very high, and that also means that lots of challenges may arise when give patients timely access to these therapies. There's different solutions or ways of approaching these drugs and access to them, and some approaches that could work is have these confidential contract agreements where the company and the government agrees on different discounts on the drugs, etc. Or we could also just restrict access to the drug to those that are in a very high unmet medical need. This was my presentation. The article is also published. If you want full text access, you can always send me an email. Thank you.
Thank you so much, Khadidja. And then to close out this part of the webinar, I'm now going to invite Eva for her presentation.
Yeah, thank you so much. So let me share my slide. So, is it okay? Wonderful. Yeah, I would like to focus on the challenging intersection of rare diseases and migration. And I will also talk a little bit about adults living with a rare disease, with a rare blood disorder in Austria. I contributed to a study that looked into the recent waves of migration of hemoglobinopathies, that is into the move of thalassemia and sickle cell diseases to Central and Northern Europe. Estimates speak of some 855,000 migrants from countries with a higher prevalence of these disorders arriving in Europe alone between 2012 and 2019, and some more ever since. Medical anthropologist Sangeeta Chattu has rightly warned about a global health crisis rhetoric in this regard. Our study, however, I think also quite appropriately emphasizes the challenges some 30,000 new patients in the European Union have to face, since they do not really fit into the dominant healthcare landscape. In contrast to countries with a higher prevalence, thalassemia and sickle cell are not included in the newborn screening in Austria. Registries are not established. The medical field and the wider public has little knowledge about these diseases, and patient organizations have not the kind of strong voice we see in endemic settings. Rarity itself is the source of many of the challenges, argue, for example, Wang and et al., and explain that the limited understanding of the medical condition with low frequency in the general population and also among clinicians, primarily with the small number of the affected individuals. This is even more so in the migration-driven rare disease setting I'm talking about. Within the Austrian rare disease community, hemoglobinopathies are also rare. They are the exotic, the other. Some 450,000 people live with a rare disease according to ProRare, that's an Austrian umbrella organization for rare diseases, and they live among a population of 9 million. Yet the rare disease support initiatives and patient activism often lack a diverse ethnic, cultural, linguistic, and biosocial presence, although it is exactly these variables, and race also in non-European contexts, habitually play a crucial role in epidemiological data and clinical trials concerning inheritable rare diseases. In such a migration-driven rare disease setting, I argue, it's not going, sorry, I got stuck, that people with hemoglobinopathies, their partners, caregivers, or even carriers of the rare genetic mutation find themselves remote from biomedical expertise, sociocultural disease awareness, and from what we medical anthropologists call biosociality. This remoteness has an enormous impact. Hemoglobinopathies are life-threatening and life-shortening diseases with complex care needs but limited treatment options. People living with severe forms of thalassemia, with transfusion-dependent thalassemia, have to deal with frequent blood transfusions and iron chelation throughout their life. And the most challenging event in living with sickle cell disease is the vaso-occlusive crisis, as Khadidja already mentioned, when sickling red blood cells cause blockages. This causes severe pain and necrosis. The intersection between rare blood disorders with contexts and biographies of migration results in these specific forms of vulnerability, because when language and institutional barriers characteristic of migration health intersect with awareness of a condition, access to quality care is further complicated. An estimated 200 people live with thalassemia and sickle cell disease in Austria. Only about 15% of them are adults. Age is another challenge here, as I will argue with respect to medical hopes. Thalassemia and sickle cell disease are very much in the focus of therapeutic innovation to mitigate or cure this single gene disorder, as already Khadidja was telling us. The first gene editing drug based on CRISPR-Cas for the treatment of sickle cell disease and transfusion-dependent thalassemia received EMA approval in February 24, and in January 2025 it was included in Austria's official list of medicines, so received market authorization. The adults with thalassemia and sickle cell disease I'm working with were first really thrilled about these new options and then very much disappointed because the indications were far too narrow for people over 30 whose bodies were already heavily impacted by the course of the disease. For these adults, medical hope easily turns into an emotional roller coaster, excitement kindled by new medical hopes and horizons then is followed by a reality check. So what I try to highlight here and to point to is 3 challenges with some ethical breadth to it. To rare disease patients that do not fit into the specific rare disease landscape due to migration. Secondly, to those outside of novel medical hope. Third, namely a generation of rare disease patients who are already too old for the cure hype of medical hopes, those who have to stick to the conventional treatments and who have have other pressing issues than the ones discussed in the rather pediatric-centered rare disease research and health policy endeavors. And pediatric is very strong here. So thank you so much.
Thank you so much for those fascinating presentations. There's a lot to pick up on. I think I'm going to start because we kind of started and ended with this. Eva, both you and Malgorzata talked about the rising significance of transitional care and the fact that rare disease research has focused primarily on children, but there's obviously a growing cohort of people living into adulthood with rare diseases. Could you just unpack that a little bit more and talk about some of the ethical challenges that we're now facing in our healthcare systems by virtue of the rising significance of transitional care?
Eva, is it all right that I start? Okay, so this is, as I said, it's kind of also a hype topic within the biomedical community. And when I mentioned earlier that the plan, especially the Polish plan for rare diseases, but a similar situation is in other countries, focuses mainly on the biomedical side. This also applies to the treatment of adults. So it focuses rather on how to provide treatment, medical treatment, but it's also where it falls short because usually the pediatric path for children with rare diseases is more or less established depending on the condition, but then people are left to themselves. So it's also the question of how much support they can get, what are the chances of getting through the system that is not very clear, not too many healthcare professionals are aware of it. But I would say that especially challenging are situations where we have young adults with intellectual disability, which is part of the disease, and who transitioned to adult care. And in the Polish context, the situation is particularly challenging because they end up in a kind of limbo in terms of care. And the system basically, the system, the law considers them adults when it comes to and expects them to be individuals, autonomous, and all these nice adjectives. But they need so much support, including support in making their healthcare decisions, that this is a situation that feminist ethicists really consider a relational ethics situation, and where the caregivers have to step in. And this is maybe, Eva, I'll pass to you.
Yeah, thanks, Malgorzata. Yeah, in Austria and in the intersection of rare diseases and migration, we find a strong need for anything that addresses rare diseases and all the things that can happen to you while aging. So what we need right now would be an expert on osteoporosis who also has knowledge about sickle cell disease or thalassemia, and you hardly find them. And if you are not so tough in the national language, it's difficult to navigate the landscape, right? So what people have to do as soon as they reach the certain threshold of coming into adult care is to organize their multidisciplinary team by themselves. And these diseases have really, they need multidisciplinary care. Sometimes in the pediatric field, all this care was organized. So they come out of a system where they had the appointment in their calendar, and if they didn't show up, somebody was calling them. But now they are in a system where they should know a lot about their disease to know what kind of checkups they would need, especially if they grow older. But that's only the medical side. The social side is also quite severe because we are talking here about people who are always in the need to explain to their surroundings what this disease is about. They have to explain why they cannot work in a regular job, perhaps, or if they have a job, why they are have to go to the hospital quite often. And we also see this this cohort of people who, thanks to improvements of the treatment, are growing as old in a healthy way so that they are able to start their own family. And then it comes also to the need to explain your child what is wrong with mommy. And that was so much of a need in Austria and the patient organization I'm working with, that they developed a children's book that should help to explain to a child what is the disease about, but also to those who read the children's book with the child. And yeah, that's what we now have published and what seems to be new on the market and addressing a new issue. Thank you.
I think that dovetails nicely with something else, Malgorzata, that you and a few others have raised, which is about kind of stigmatization within the biomedical paradigm of rare diseases. And so you can see policies, you mentioned patient passports, that might be implemented with a view to helping patient communities, but actually end up having negative or harmful effects. Could you talk a little bit more about that, whether with that example or another?
Okay, thank you so much. So this was definitely a topic of one of my articles published in Social Science and Medicine, and I think it has become really important with the COVID pandemic, where the passports, healthcare passports, were suddenly a topic, and that's also important within different legislations and different ideas of how to help people with rare diseases. And one of those ideas are patient passports or patient cards. And the idea is actually very, I would say, it's a simple that, okay, we have this either electronic or in some cases paper document that contains all the history, and the document should help. Yeah, and now the question is, who is the addressee of the document? Because in my paper, I noticed after talking to patients, patient organization representatives, that the Polish version of the document was basically addressed to healthcare professionals. That wasn't so much like in the UK version that has this really nice Cambridge, this is me, and this is like the story of my life, and that the patients could put more than just their treatment plan there. But the Polish version was very much focused and addressed the perceived lack of knowledge on the side of healthcare professionals who are going to treat the patients. And not so much, that's the biomedical focus, not so much the person as a whole, as also, let's say, their some other needs, for example, not the ability to communicate properly, or some other emotional issues that may also impact the delivery of care, but are not recognized by this document and by the whole idea of the passport. So that's why I use this term paternalistic or pathogenic vulnerability, because we have a population that is considered already vulnerable, even if we don't always agree in social science with the term vulnerability and how it's defined. But by introducing, instead of looking at individuals and what actually comes into this vulnerability in individual and single cases, we pathologize them and treat them as kind of I would say in part by default. Similarly, and also we really treat them as not being able to speak for themselves and express their own needs and wishes and concerns and everything. So maybe I don't really want to take the space and time.
Before I move on, did any of the other panelists want to respond to any of that? Maybe I'll move on now to questions about pricing and budgets. Khadidja, I thought your analysis was really fascinating. And I guess I wanted to come back to your discussions about how we might meet some of these budgetary challenges. You talked about confidential contract agreements and kind of focusing on high unmet need patients. But yeah, I mean, I guess I'm curious to know if you could unpack that a little bit more. Is this just hypothetical at the moment, or is this being implemented in any other jurisdictions for very expensive treatments currently?
Okay, thank you for your question. So these type of agreements are currently implemented for mostly high-cost drugs, so which is usually the case with rare diseases, and they're more so known as managed entry agreements. Usually when a company delivers their analyses, so they prepare the budget impact analysis and other cost effectiveness analyses, they submit it to the reimbursement committee, and they go over the analyses and their dossier. Then they kind of come back to the company with their thoughts. And usually for rare diseases, these analyses are, people say they're flawed because of the high cost of these drugs. Because if you look, for example, if you have a threshold, usually the drugs that are developed just go beyond those. Now, it shouldn't mean that patients shouldn't get access, because these hard numbers say that, no, it's not affordable, no, it's not cost effective. So in those situations, they try to kind of compromise or come to an agreement with the company. And some agreements are financial based. So the company and the government agrees to a confidential discount. For example, 40% is usually what we think is given. But also there's other innovative payment schemes that they might have been implemented already, but as they're confidential, we don't really know. But other types of agreements is, for example, let's say if the drug is reimbursed for a period of 3 years, then the company has to provide evidence that the drug worked. So then what they do is monitor the patients and see if certain criteria are met that they agreed upon beforehand, that then shows that the drug is efficient. If, for example, those type of criteria are not met, that's when the company is supposed to pay back a portion of the profits that they have made to to the government. So these types of agreements are very common in the rare disease area. However, there's a lot of critique on them as well. And many countries like Belgium are trying to step away from those agreements because transparency is more valued at the moment, but they are indeed implemented. Yeah.
Yeah, fascinating. Thank you. And I mean, out of interest, when we're looking at these kind of multi-million euro impacts, in the budget analyses, are you factoring in what happens if the patients don't get treatment in terms of all of the emergency room visits, pain management, lost productivity? Is that kind of factored into the analysis?
Exactly. So I haven't gone into that in detail, but the analysis did look at, for example, it first looked at the drugs, the medicines that are used, the drug costs, but also the visits to hospitals, certain specialists, and also, for example, if the patient is cured with the gene therapy or the stem cell therapy, what costs are eliminated. So it kind of tries to make a balance of the costs, but also the savings of introducing a new drug, but not only focusing on drug costs. That's recommended, although we do see, or in my PhD, I've also looked at different budget impact analysis that were done in the past. Usually companies or in these analyses, they do focus on drug-only costs, which is not the recommended method. But in my analysis, we try to look at the holistic care of sickle cell disease.
Thank you. I'm going to pick up a question from the attendees now. And Wim, this might be one for you, given you were arguing that rarity shouldn't be a factor in reimbursement decisions. But there was a really interesting question here about whether any of us are thinking about the ethical implications of monetary thresholds on new therapies in terms of systems like France, where there seems to be a threshold per drug or disease, if we understood correctly, versus places like the UK, where there's a threshold per quality affected life year. So again, correct the questioner if they're wrong, but as they understand it, the quality metric is insensitive to how many patients there are, whilst the former measure seems sensitive to the prevalence of a disease. Would you want to pick that one up, Wim?
Yes, I certainly understand the remark, because a threshold is like objective, transparent, and people like it a lot. From a patient perspective, it can be highly problematic because it's also very man-made and arbitrary. So how do we look at this? I think Khadidja explained very well that the pricing and availability is the outcome of a negotiation process, that we don't need to be happy, I want to add, with prices. I think we should be very critical about the high amounts, but we have power imbalances during the negotiation process, which might change over time in companies that we really need to develop drugs to help people to get out of their unmet medical need. On the one hand, societies that have some power in deciding whether or not they reimburse and there's a market or not, because that's the power we have as a society to say we pay it back or not, and if it's not reimbursed, there's no market. But it's a process that can change over time. So once a new drug comes over the market, sometimes it may be justified or something we could consider to pay higher prices if we can anticipate on what's coming and see whether scientific proof on the outcomes and so on evolves. I think as a society, we should not lose the patient out of sight because of a certain threshold. If you have an unmet medical need, it doesn't really make sense that there's an upper limit, because the upper limit is just an amount. Living without limits is disastrous for a budget as well. So we cannot do. We need to think, and we need benchmarks. And I think sometimes a limit can make sense. But for example, in Belgium, to my knowledge, we don't have an upper quality threshold, for example. But of course, there's a discussion, and I think there's always points of reference that are used in a discussion on how much something should cost. but situations are very complicated. I think within the 200 plus approved orphan drugs, the reasoning can be quite different, and case by case there are big differences in the kind of patients that use them, what's already available, the cost of non-treating and so on. So it's really tailor-made work, and we need to keep that in mind. I think just reimbursing without having a plan on the longer term is a bad idea. So I think it's good to anticipate and in the negotiation build in the best power you can have as a society to take care both of the people with unmet medical needs and the public finances.
It's interesting on this point. I mean, you mention this idea of kind of production cost. I mean, you're critical of value-based pricing, and you mentioned this idea of production cost plus reasonable profit as one pricing model. But, you know, I mean, again, I don't know, this is somewhat hypothetical, but if, for example, it costs 100 million euros to develop a drug, but then there are only a few hundred patients globally, what would be a reasonable profit margin? I mean, it could still result in these treatments costing.
I know it's too simple to apply to orphan drugs. And what happens is also you often get the argument, yes, but developing new drugs is trial and error, and you have to get a payback on everything that didn't work out. Now, ethically, you can ask how fair it is to pass the bill to the few people who have the bad luck of having a rare condition. So in the entire system, it's difficult to find balances. And of course, just saying the production cost is I don't think it's a good system, as is the case with art, because the situation is more complex. But value-based pricing, in which you say, what do we save, is equally not a good system, because you may seriously overprice. And there's also a big difference between companies. Some companies invest a lot of money in research and high-risk research. Other companies don't, and they still bring orphan drugs to the market with a high profit margin. So it's also a case-by-case evaluation. It can be really different depending on the specific drug and the specific audience.
This is a little bit out of left field, but I'm curious for the panel's perspective on the ways in which you know, AI and AI-enabled drug discovery is changing the landscape of research into rare disease treatments, if at all. I'm not sure quite who to address that to, but just thought I'd throw that out there as a curveball. No, maybe it's not the right question for the panel. I think actually at this point, did someone want to jump in there?
Actually, not so much. I think it's also like an emerging field, but I had a comment on Wim's and Khadidja's also, or addition to what they said, and something that we are overlooking in the pricing, namely the people who patients who participate in clinical trials, and they do it because of the hope, and it's like a driver that it's not really counted into the price. So we just think about the companies, how much profit or no profit, and what the price tag we can put, but we don't really think about that emotional and social aspect that I think it's also raises ethical questions that are not monetized upon. So this was something I wanted to add before AI, and I think with AI we still need some time to think about. Thank you.
Well, look, I think this is a nice moment actually I'll take as a comment. There's been a comment come through on the chat from an attendee who comments that you know, there are currently 6 million people who are patients living with rare diseases in Europe, and we haven't got them represented here today. And I think, you know, that is something that's important to consider, and the role of the patient community. And some of you mentioned kind of patient advocacy, which plays such an important role in some other fields in healthcare, and yet in the case of rare diseases, seems to be a more difficult space. I mean, of course, partly this is probably because of the heterogeneity of rare diseases, but I wonder if the panel could comment at all on patient advocacy, and, you know, perhaps I'd be interested to know more about whether there have been any instances of patient advocate groups running up against sort of these thresholds or limits or even regulatory processes that you mentioned, Khadidja, for orphan drugs.
think it's indeed a very heterogeneous field, ranging from patient associations who co-fund research and actively have a say in what's going on and how it's going on, to patient groups that are still really dependent or have even few outlook of any research interest in their domain anyway. So it's difficult to have a consistent story for the big heterogeneity that's there. Maybe to pick up on the previous comment as well, I think it's very important to recognize the efforts being done to participate in clinical trials as well. And an important way to do it is to provide post-trial access, which isn't always done in a systematic way, that people who participated in the trials, at least those who participated, can get access until national governments would have the chance at least to reimburse, and it's EMA approved and on the market. And that period is often very vulnerable for patients to still get access, especially if they got a major improvement of their conditions during a trial, and there have been documented cases in such respect.
Thank you so much. I'm conscious that this hour has absolutely flown by and we're already past the hour. I believe Khadidja is actually going to have to jump. So maybe we'll let you go, Khadidja, with thanks, and then I'll just ask a couple of final questions.
Thank you so much for inviting me. It was an interesting conversation. Okay, bye.
Thank you, Khadidja. So I suppose maybe I'll sort of end the conversation by asking each of you if there was just one thing that you could change about how societies deal with rare diseases. What would it be? What do you think would have the biggest impact on the lives of patients and families? This might be at the level of policy. It could be at any other intervention.
Maybe if I can add it and also pick up on that engagement of patient organizations, maybe listen more to the voice of the patients, but not only to the voice of the patient organizations, because what I've noticed in my is that many, I don't know how to do it practically, because we have also those kind of geographical challenges and other issues, access challenges, but how to listen to the voice of patients, growing up patients and their caregivers, in a way that it's not discriminating and not patronizing, that we know what is better for you guys, and it's not the approach that I think is sustainable and very, very helpful. So I would call for that, more engagement on different levels, and this,
Thank you.
I would maybe argue to join forces. Reimbursement is decided at country level in non-transparent agreements. Every country trying to serve its own interests, which is not always in favor of patients, also creates big differences throughout or within Europe. And joining forces could maybe be in the benefit of all stakeholders involved in the end.
Eva?
Yeah, I would highlight also that to have the patient voice is also work. And what we see in the patient organization I'm involved with, there is a lot of demand. We have every third week there comes in some event or some pharmaceutical company who wants to have the patient voice, right? And some of our patients are really, they trained themselves over the years. They combine the medical knowledge with the social knowledge of what it means to live with such a disorder. But actually, it's provided for free, and it saves the system a lot of money, because they send newly diagnosed patients to exactly these organizations and expert patients. And actually, this is a lot of work that supports the system. So what I would change, and that was your question, Sally, I would invent some kind of financial support for this kind of patient organizations and expert patients. Yeah.
Thank you so much. I really appreciate the quality of the discussion. We've covered a huge amount of ground. I do apologize that we weren't able to go into detail on every single point. There was just so much to unpack. And I apologize too to those of the audience who asked questions that we weren't able to address, but I'm sure the panelists would be happy to pick that up afterwards. I think this has been a fascinating discussion for me, in the sense that, rare diseases offer this prism that force us to confront, quite uncomfortable truths about healthcare, about access and medical need. And, it's quite clear too that policies designed to help patients can often end up making their lives harder, and we need to kind of move into new paradigms of sort of understanding rare disease treatment and its effects on patients and families. So really appreciate you all being here, and thanks also to the Brochet Foundation for having us, and look forward to seeing some of you at future meetups, I hope. And thanks again to our panelists.